So hemodynamics, we are looking at gradients that drive the blood pressure through the body. It's the physiology of blood flow. The heart force drives the pressure through vessels by creating a pressure gradient, so that gradient is highest at the left ventricle and aorta and lowest when we come back through the vena cava to the right atrium. Blood pressure decreases as it moves further away from the aorta and left ventricle. Blood flows down this gradient from high to low pressure. So this is why pressure is almost zero when it gets back to the right atrium, and the aorta is the highest pressure vessel in the body. The magnitude of blood pressure gradient is the factor that determines blood flow. So blood flow is the volume of blood that flows per minute. So generally your flow matches your cardiac output. You tend to have about 5 to 6 liters per minute flowing, and it is directly proportional to the pressure gradient, which means that blood flow increases when the pressure gradient increases. Blood flow decreases when the pressure gradient decreases. And this is why it's so important to have the blood pressure being really high coming from the left ventricle and aorta, very low coming back to the right atrium, because that gradient, that bigger difference, is what drives blood through the body, and the heart gives that push as it leaves the left ventricle, and of course it's lost some momentum as it gets back. So that is going to drive the blood flow. Now if we look at the velocity, that is determined a lot by the cross-sectional area, which is helped as vessels branch off progressively smaller as we go through the body. So how we really should see this is we have large arteries that branch off into smaller arterioles, which then branch off further into smaller capillaries. So each time we see this, this would be like an artery branching off into arterioles. Then we could compound more of the smaller vessels coming off into capillaries. Several capillaries would come back together, making less venules and then into larger veins. So as it branches off into progressively smaller vessels, the cross-sectional area increases, and that causes blood flow to decrease. So what we see is we've got the largest cross-sectional area in the capillaries, where we have the bulk flow and the transmission of fluids and things coming out into tissue cells. So we want our blood to go slower through those capillaries so that we're able to get the oxygen and nutrients to the cells and pick up waste and CO2 there, and then it can go a little bit quicker as it comes back out. But we have that largest cross-sectional areas at those capillaries because we need more time there. And of course the velocity is the fastest in the aorta, where it's there at the highest pressure, and we have a very large large area, not smaller areas of cross-section. So we can see here, of course, that pressure gradient, very high when we leave the left ventricle, very low when we get back to the vena cava and right atrium. And a lot of this is generated by the contraction of the ventricles on the left side of the heart in the systemic circuit. There are 3 things that determine blood pressure, and these are very important to remember. CO stands for cardiac output. Cardiac output is the amount of blood ejected from the heart per minute. Blood volume, the amount of water content or the amount of blood in the vessels, and vascular resistance. And resistance is anything that impedes blood flow. We'll talk about several things that can cause resistance. But the higher the blood pressure, the higher the flow is going to be. So resistance, we said, is opposition to blood flow due to anything that impedes blood going through the walls, any friction. The higher the resistance, the less flow we're going to get. 3 things help determine resistance. The first one is the size of the vessel lumen. How can we affect the vessel lumen? Vasoconstriction, which makes that lumen smaller, will cause more resistance. Also things not vasoconstriction related, but things like plaques and arteries can cause resistance, which is why coronary artery disease or a vascular disease can cause higher blood pressure. Blood viscosity, this means that blood has more thickness, or polycythemia, where you have a high hematocrit. This can cause blood to flow less. Dehydration, where we have a lower water content in the plasma, can also cause this, as well as total blood vessel length. The longer a vessel length, the more impedance to blood flow, so the higher the resistance. Obesity, because whenever there's extra adipose tissue there generated, you've got to supply that with longer vessels. That will cause resistance to go up, which is one reason also that obesity can cause high blood pressure. Hypertension is persistently high blood pressure. It is a major cause of kidney disease, heart failure, and stroke. There are two types of hypertension. There's primary or essential, which is not attributed to an identifiable cause. Some people will just have essential hypertension where it runs higher, and they're always looking for causes. Secondary hypertension is there is an underlying cause that is making that blood pressure high, and that could be many things, such as something obstructing blood flow to the kidney that could cause excess renin, which we will see puts into account the renin-angiotensin-aldosterone system, which will raise blood pressure. Kind of related to that system, if your adrenal cortex is secreting large amounts of aldosterone, which increases your blood volume, that will increase blood pressure. Or a hypersecretion of epinephrine and norepinephrine, those stress hormones from the adrenal medulla, will cause increased vasoconstriction and will also cause high blood pressure. A normal blood pressure is anywhere from 100 to 120 systolic pressure and 60 to 80 diastolic pressure. If your systolic pressure is 120 to 139 and diastolic is 80 to 89, that would be pre-hypertensive, not hypertension yet, but pre-hypertensive, where you may need to change some lifestyle factors. Stage 1 hypertension is where your systolic pressure is 140 to 159 or your diastolic is 90 to 99. Stage 2 hypertension is very high. This is where your systolic pressure is anything greater than 160 and diastolic is greater than 100. So we go over blood pressure in lab, but systolic pressure, that first number we said should be anywhere from 100 to 120 millimeter mercury. And what that means is it's synonymous with when the ventricles are in systole. Diastolic pressure should be 60 to 80 millimeter mercury, and that is when the ventricles are in diastole. So the factors that affect blood pressure, we said, are resistance, which is determined by the vessel radius, blood viscosity, blood vessel length, or obstructions like plaques in the vessels. Cardiac output, which is determined by your stroke volume times your heart rate. So a high heart rate or high amounts of blood being pumped from each ventricle will affect the cardiac output and making it higher, as well as blood volume, which has to do with water loss and water gain, largely associated with hormones. So all of those things will determine blood pressure.